Welcome back. So now we're talking about sociological investigations into psychiatric nosology. So what I will say is that this is a fancy way of just saying the way that sociologists view classification of mental disorders. So the influence of the DSM extends into sociology, which makes sense. The way that we classify disorders has an impact on how we interact socially, on social systems and institutions. Many sociologists do use scales from the DSM, but they're typically critical of it, although they still do use it. And the DSM is typically not taken at face value, but is used as an object of analysis. So much sociological research assumes a social constructionist approach to psychiatric nosology, which means that we as society create the disorders, we create the norms around appropriate behavior, and that the way that we understand mental illness is really socially constructed. Sociological research also attends to the ways that our definitions and understanding of mental illness are shaped by social factors. So what we'll be talking about today are the three main areas of social investigation related to the DSM. The first one is the role of the DSM in encouraging medicalization. This should be familiar. We talked about this. Two, the impacts and influence of the DSM on clinical practice. And three, the manner in which the DSM shapes patient identity and experience. So if you think about it, I told you guys that there are really three levels here of sociological research. There's the macro level kind of medicalization, kind of the meso level diagnostic, business aspect, and then the more micro level patient experience. And so we'll be talking about how medicalization has been increased, kind of the impacts of that, the perspectives on that. We'll talk about the patient-psychiatrist relationship, and then finally the patient experience. And honestly, they all do tie together. So when I say medicalization, what do I mean? All right, so really it's just the redefining of social problems into medical illnesses. And so the way that we understand suffering, sadness, emotion, urges, desire have been transformed into mental disorders. So if we think about the DSM-1 and the DSM-2, which like I said before in the last lecture, weren't really focused on diagnoses, the DSM-1 had 106 disorders and was 130 pages long. The current DSM has 541 diagnoses and is almost 1,000 pages long. So this is what I mean by medicalization. We're increasing this. And not only that, but we have what's called diagnostic creation. Diagnostic creation can simply be understood as creating new diagnoses, new ways to be mentally ill, new reasons to be treated by psychiatry. So if we think about ADHD did not exist prior to the 1980s. So ADHD is only about 40 years old in terms of diagnoses. Disruptive children would not have been labeled as mentally ill prior to the 1980s. Now we have 1 in 10 children being diagnosed with ADHD. That's about 6 to 7 million children. So again, 40 years ago, 0 people had ADHD. Now, just in children, 7 million children have ADHD. That's medicalization. That's diagnostic creation. We're creating new diagnoses, new ways to be mentally ill. And so I'm curious, and this is an effort-based question. However, you have to have paid attention to lecture or previous methodology classes to understand what I'm asking here. So at what point does high prevalence become evidence against the validity of a mental disorder? So go ahead and think about that. First, identify the italicized words, and then go ahead and answer this question with your own thoughts. So then we have diagnostic expansion. So this is whenever you expand a diagnosis, when the criteria for existing disorders become changed in a way to increase the number of potential patients. So there are a couple ways this happens. One is by lowering the duration of time. So instead of saying you have to be, depressed for at least 3 weeks to be diagnosed with depression, it might be that you have to be depressed for at least 10 days. Or it could also be with decreasing the amount of symptoms you have. And so instead of having to have 7 out of 9 of the criteria for borderline personality disorder, now you only have to have 5 out of 9. So diagnostic expansion is really just expanding the criteria to include more people in it. So diagnostic creation, creating new diagnoses. Diagnostic expansion, expanding the criteria so that more people are considered, or more people collapse under this diagnosis. So I'll give you the example of PTSD. So the DSM for broaden the notion of what is considered a traumatic event. And so it's not just wartime. It used to be wartime, but now it's not just that. And so it can be, receiving a distressing phone call that reminds you of a traumatic event. That would be eligible for a diagnosis. And so now trauma is defined as any event outside the range of usual human experience that would be markedly distressing to anyone. And so it reorients the diagnosis to subjective reactions of individuals rather than objective identifiable causes. So in the past, a traumatic event was defined as, by qualities of events. Now it's defined by individual responses. And so there's a change then in what it means to experience trauma. The PTSD diagnosis has been expanded to include witnessing or even receiving information about a traumatic event. And so if we think of examples like witnessing police brutality, prior to the diagnostic expansion of PTSD, the only person that would be able to have PTSD would be the person who was the direct recipient of police brutality. Now PTSD can include not just the person who was the victim, but also people who saw it and recorded it. And then the people who watch the video on TikTok or Instagram can also now have PTSD. That's diagnostic expansion. The fact that it used to be the small, very specific niche, and now just by hearing about information, not even experiencing it, by hearing about it or watching it, you can now have PTSD as well. So that's one way that distress has increasingly been medicalized, by creating new categories, new ways to be mentally ill, and making it easier to qualify as being mentally ill. So what has driven this growth of medicalization? A lot of things. It's not just one. It's not that, it's just big pharma or psychiatrists are bad guys. There are a lot of reasons why medicalization has been increased. So psychiatrists, there are professional considerations. Again, the legitimacy of the field. Pharmaceutical companies. I'm not going to sit here and say that, big pharma doesn't care about diagnoses. They do. I mean, it's just truth. The more diagnoses there are, the more people that can fit that diagnosis, and then the more medications that can be produced and marketed and tested to treat those growing number of people in those growing number of categories. So it's not that I'm saying, all this is big pharma, but yes, pharmaceutical companies do benefit from increased medicalization just from a financial standpoint. Insurance companies, getting a prescription for lamotrigine or for lithium, for Xanax, is going to cost your insurance less than if you are in, weekly intensive outpatient therapy, Monday through Friday, 9 a.m. to 3 p.m. Regular intensive psychotherapy costs more than a lot of medication, especially with generics. So insurance companies are also invested in a medicalization of distress. And again, it's not just that pharma is bad, psychiatrists are bad, insurance is bad, and the patients are suffering. Patients also benefit. One, medication helps. It's not the only thing that can help. And I find it unfortunate that medication is increasingly marketed as the only solution. However, I'm not going to sit here and say that, if we just read sociology books, we'll be cured. No, some people need their meds, like for sure, 100%. So patients do benefit from this because medication does help. Not even that, but recognition, understanding, and access to resources. So if you tell somebody, or if you're talking to a friend about somebody who was experiencing or who was, expressing erratic behavior, and you're talking about this person who had erratic behavior, and someone says to you, well, yeah, they're bipolar, but they're on lithium and they're managing it. That can make you feel softer or more understanding of the person. And so whenever we have these diagnoses, whenever we view things as medical, that can decrease the stigma. That's why if you've ever seen people say, the argument that the same way that heart disease is a sickness of the heart, or lung cancer is a sickness of the lungs, depression is a sickness of the brain. That kind of like analogies that like mental health is like other health, it's just that your brain is sick or your mind is sick. The reason that people use that logic is to decrease the stigma. Because if you can make the argument that your depression, your behavior, your urges, your neuroses are medical conditions, then that insinuates that it's out of your control. And if you can then on top of that say, but I'm medicating it, I'm taking medication for it, well, then that legitimizes you and can again decrease the stigma. So not only do psychiatrists benefit and big pharma benefit, but patients also benefit in many ways from the medicalization of distress. Although, of course, as we spoke about on Tuesday, there are ways that, patients are also harmed by this. Medicalization of distress also looks like the decontextualization of distress. Excuse me. So decontextualization, the tendency of the DSM to fail to acknowledge the ways that mental distress are determined by and situated in social structures and cultural meaning systems. What do I mean by that? Basically, I'm just saying that decontextualization is taking the social context out of mental illness. And so you're basically reducing mental distress to the brain or genes and ignores social origins. So for example, women are more likely to have anorexia than men. If I was only looking at genes and chemicals, I might say something like, well, women and their small brains and their estrogen, that's why they have anorexia, but that would totally ignore the social pressures that are placed on women to attain ideal body image. If we were to say, well, men don't experience anorexia, and that's because men have bigger brains and they're just mentally, wired to be stronger. Well, that doesn't take into account the fact that men do experience body image issues, but they're not really allowed and encouraged to talk about their body image issues. Men don't self-report having anorexia because it's stigmatized for men to express this. And so if we only look at brain chemistry and genes, we can ignore the social origins of social pressures and norms and expectations that impact us. If we ignore the social context, we can misinterpret normal reactions as pathological. And so if you, have a low appetite and increased sleep, if you do, don't do this, but hypothetically, if you know of a friend who did Adderall for, 2-3 days on end to prepare for finals week, and then after the final exam, they sleep for 2 days straight and barely have an appetite, does that mean that they're depressed? Because look at it. They might have little interest in doing things that brought them pleasure before. They're not getting out of bed, so increased sleep, decreased appetite. You could say, well, that person, based on their symptoms, based on their symptoms, they have depression. But in reality, no, they're just crashing because they did Adderall for 3 days on finals week. And so that's kind of medicalization. If we decontextualize and we take out the social factors, and that's a problem because we have normal reactions, maybe not to the healthiest of, causes, but we can have we can have normal reactions, natural reactions that are then interpreted as being a diagnosis or being, evidence of a mental disorder, when in reality, it's just a natural reaction. So that's an example of decontextualization, taking the social context out, saying that women have bad brains versus saying, women are pressured to attain, beauty ideals. So then diagnostic practices, increasingly social research is turning its attention to how the DSM is used. So we talked about medicalization, kind of that macro level social impact. Now we can think about diagnostic practices. How do these social forces, how did this medicalization impact the actual diagnostic relationship between psychiatrist and patient, excuse me. And so this institutional infrastructure of mental health is based on DSM diagnoses. but how the DSM shapes these relationships are less straightforward. And so psychiatrists often experience tension. I'm not saying psychiatrists are the bad guys here. I'm not saying, patients are suffering and psychiatrists are rich and by golly, we got to stop this. That's not what I'm saying. Psychiatrists also experience tension. So they have the need to secure professional authority through medicalization, through the DSM, but they also want to exercise professional autonomy. And so many psychiatrists will develop workarounds that allow them to stay formal, keep their job, keep their credibility, while also being able to have some independence. So using alternative diagnostic systems is one way that psychiatrists will do this. And then they'll translate their own scale into the DSM. They might fudge diagnoses on paperwork. So maybe saying that somebody is bipolar instead of borderline, for example, to help them get a certain treatment, but the DSM wouldn't recognize them as that. Negotiating diagnoses with patients. And so if a patient is struggling and they need a certain treatment, but maybe they can't access that treatment without a certain diagnosis, the psychiatrist might talk to the patient and say, hey, listen, I know that you don't have OCD, but if we say that you do, then you can go to this cognitive behavioral therapy that, having anxiety might not get you into. And so psychiatrists also experience tension. Many of them are trying their best and they do find workarounds to exercise autonomy in their profession. So the micropolitics of medicine. The micropolitics of medicine refers to the way that larger structures of power manifest at the level of the doctor-patient relationship. So if we think about larger structures of power, racism. So micropolitics of medicine could be the way that racism manifests at the doctor-patient level. So the fact that we see overdiagnosing of Black children with oppositional defiant disorder. The way that sexism manifests at the doctor-patient interaction. So the fact that we see the underdiagnosing of women with autism, the overdiagnosing of men with autism. That's an example of sexism and gender inequality and gendered beliefs that are manifesting at the level of the doctor-patient relationship. Classism, if somebody, comes in to a psychiatrist and, it's a rich housewife and she's saying, oh, I'm so miserable, life is so hard, they might not take her that seriously because, what do you have to worry about? You're fine. It's that kind of idea that classism, racism, ableism, sexism, these can all embed themselves at the level of the doctor-patient interaction. And so even though we have psychiatrists often doing their best, practitioners trying to exercise autonomy, trying to negotiate with their patients, it's also simultaneously true that the same way that you and I are socialized, so are psychiatrists. And these social forces like racism and sexism and classism and ableism, they also have, seeped into the psyche of psychiatrists. And that's the micropolitics of medicine. So we had medicalization at the top, the doctor-patient relationship as the diagnostic practices, and then we also have diagnosis and patient identity. And so we have to ask ourselves, what are the implications of these diagnoses? What are the implications for patients and their illness identity? And so we have then what's called classificatory looping. So this is the way that categories kind of self-reproduce. The ways of being the mental illness reproduce the thing being classified. So dissociative identity disorder. Being diagnosed with DID can provide a template for how to be DID, for how to have DID. And so, for example, you might have somebody who prior to the diagnosis never had alters, but once they get their diagnosis, they have alters. And once they get their diagnosis, now all of a sudden they're remembering false memories of abuse. Because they're reading that, oh, if you suffer childhood abuse, that's why you have DID. And so people who are looking to make sense of their diagnoses might say, oh, well, I guess I do remember that one time when maybe somebody hurt me. Yeah, and like our brains, our memories, it's actually scary how our memories are not that reliable. You can kind of convince yourself of anything if you are in the right mindset. It's very scary. And so we see classificatory looping with dissociative identity disorder, where people who are diagnosed with this will start to procure, not always, I'm just giving examples here, where sometimes people with this disorder will then create false memories to kind of explain why they had that disorder. PTSD. So without the diagnosis, you might interpret your memories of war or trauma very, very differently. So once you get a diagnosis of PTSD, you might become that diagnosis. And so if you are a war veteran and you get a diagnosis of PTSD, well, now every 4th of July, you might expect yourself to be triggered by fireworks, even though you were never bothered by them before. If you were in a traumatic car accident, if you were in a car accident and you tell your psychiatrist and they say, oh, well, you'll likely experience some PTSD following that event. That's normal. And now every time you drive, you expect yourself to be on edge. You expect yourself to feel nervous. But had you not been told you have PTSD, you might have just been driving fine. So it's the idea that once you have this disorder, you begin seeing yourself as someone with this disorder, and you kind of start filling in the blanks. And so in any given period, there is a symptom pool of recognized ways to express psychological suffering. We adopt these unconsciously, subconsciously, and we experience our distress accordingly. And so society tells us how to be sick. So for example, you might say like, oh, I'm depressed, I just want to stay in bed. But in reality, your room gets super hot, there's no AC in your room, the TV is in the living room and your couch is way more comfortable. And so even though realistically you'd much rather be on your couch, you'll say things like, I don't want to get out of bed, because that's the tagline for depression. You just stay in bed. Maybe your bed's not comfortable, but you'll say things like, I just want to stay in bed. If you are depressed and you have an appetite and you are super, super hungry, you might not want to tell somebody that, because low appetite is one of the main signs of depression. And if you say like, oh, I'm so hungry, I just want to eat like a super nutritious meal, that might make somebody think that you're not actually that depressed. So society tells us how to be sick. And there's also a fear that if we don't act that way, we won't be taken seriously. So if you do, go to the gym, and you're telling your friends, man, I'm more depressed than I've been in years, but you're going to the gym 5 days a week, they might pull on their symptom pool knowledge and say, unconsciously, they can't be that depressed. Or, well, she must be getting better. Oh, she has an appetite now, she must be getting better. But in reality, you feel just as terribly, but there's that symptom pool. There's a way of being depressed. That's classificatory looping. So patients and their advocates seek recognition of disorder statuses. Again, it's not just that, big pharma and psychiatry and insurance companies are the bad guys and patients are suffering because of these diagnoses. Having these diagnoses can be really, really, really helpful. So one, a diagnosis provides legitimacy. Like I said, if you can say, well, you take the heart attack seriously because it's a problem with the heart. Take my panic attack seriously. It's a problem with my brain. Being able to say this is a medical diagnosis that requires medical treatment provides legitimacy and can make you be and feel less stigmatized. This isn't always the case. So schizophrenia is considered to be a medical diagnosis that is still very stigmatized. So I will say take it with a grain of salt. Not all medical diagnoses are, decreased stigma, but generally speaking, once you have a diagnosis, if you're exhibiting erratic behavior or hearing voices, or experience or portraying, deep sadness, and you're experiencing these emotions, except one scenario, no one knows what's wrong with you, quote unquote. The other scenario, you have a diagnosis written by a psychiatrist and it's prescription. It's more likely that the version of you that has a prescription and the diagnosis will be less stigmatized. A medical diagnosis provides an interpretive schema. And so it's a way to understand your diagnosis. And so if you have a sense that something's wrong with you, you just feel off, You're different than other people. You never feel quite right. You never feel at home. And that's isolating for you because you think I'm the only one who's ever felt like this. And then your doctor tells you, no, you have, we'll go with borderline. You have borderline personality disorder. That can make you feel seen. Now, every time that you went from idolizing your partner to hating your partner, now you think, I'm not crazy. I have this personality disorder. It can explain behavior and make you not feel alone. So it's not just, I'm the only person who ever felt this way. What's wrong with me? It's, oh, there are millions of people who experience this as well. That can help you interpret your behavior. It can serve as a basis for your identity. And then having a personal problem being medicalized can also help you secure resources, not just compassion, but also treatments. And again, medication does help people. I'm not sitting here saying that we should just read sociology and, screw medication and biology. No, I'm saying that we have to take all of these into account. Some people do advocate to have diagnoses removed, and that's typically because the diagnoses carry stigma with them. So if we think about homosexuality, if homosexuality was put back in the DSM, there would be an uproar. There would be protests. People would be sued. Companies would be sued. Because if you say that homosexuality, that being queer is a mental illness, that is no longer socially acceptable. It's normal to be attracted to people of the same gender expression, as the same sexual identity. That's seen as, that's for the most part generally accepted as more normative than previous decades. And so it makes sense to us, probably quite intuitively, why homosexuality, why queerness shouldn't be in the DSM. But what about gender identity disorder? This one's tricky because on one end, we don't want to pathologize trans people and NBs, non-binary people. But also remember what we talked about earlier. These DSM codes are used for billing purposes, hospital admittance, insurance purposes. And so if you can say, I need this surgery, I need these hormones, I need this therapy, because a credible DSM says I have a medical disorder and I need these medical treatments for my health, your insurance has to pay for it. You're seeking a medical treatment to a medical disorder as decided by a credible source. If we take GID, if we take gender identity disorder out of the DSM and someone says, well, the insurance company could argue it's a personal preference. If it's not medical, if it's not health related, we don't have to pay for it. And so it's difficult because there are disorders that there are experiences that when we classify them as disorders, it can help people seek help and treatment. But also the flip side is that you have people who are less tolerant, who will say, oh, well, this is a mental disorder. These people are sick. I know that they're sick because psychiatrists agree that they're sick because they're medicated for it. So it's tough. Premenstrual dysphoric disorder. Hormones rise and fall, bodies change. Estrogen levels, rise and decrease. And so if we start diagnosing people as having premenstrual dysphoric disorder, when in reality they're just having hormone changes, well, that can also lead to gender inequality. So underlying these efforts to remove diagnoses from the DSM are stemming from longstanding concerns about deviance and social control. So the removal of homosexuality from the DSM by Robert Spitzer was about decreasing the deviance and the stigma. The desire to remove Asperger's, GID, PDD are an interest in decreasing the stigma. And so the idea is that the only reason that they're in the DSM is to police, and control deviance. Support for this idea is that there's an increase in medication, especially in disadvantaged children. And so we see that children in foster care and Medicaid excuse me, the children on Medicaid, Medicare, and foster children are prescribed medication at some of the highest rates. And so when we see things like this, that two children can have the exact same behavior, one white and rich, one black and poor, and the black and poor kid's going to get 30 milligrams of Adderall, and the white rich kid's going to get, he's just creative. We can see why there's a concern about these diagnoses. But again, it's tricky because if we remove these diagnoses, we're also going to threaten removing treatment for people who rely on them. So it's not an easy solution. So in conclusion, the uncertainty surrounding our basic knowledge of mental illness has elevated our concerns, our classificatory concerns, to a prominent political place for everybody. The experience of distress encompasses the complex interaction of neurology, psychology, social factors, and it's unlikely that we can reduce any of this to one factor. So what I would like you to do, I would like you to pick one of these questions and write one full paragraph on what you think. Not a whole paper, just one full paragraph. This is effort-based. So any one of these questions, pick one. Should mental illness be viewed as a mental condition or a social problem? Will diagnoses pathologized today as disorders become later recognized as acceptable diversity, like homosexuality? Who should be granted the authority to define and treat mental distress? Will we look back on this era of psychopharmaceutical use with the same regret and dismay that we look back on lobotomies and electroshock therapy? Do advances in neuroscience represent the way forward, or are these advances a misguided attempt to reduce complex factors to just being biomedical? A medical diagnosis can secure benefits, but at what cost? So pick whichever one is most interesting to you and go ahead and answer that. Okay. I'm going to give you a quiz and then I'll touch back in a little bit with your last lecture.